Hi, everyone. Welcome to Texas Primary Care Consortium's monthly Monday Primary Care Talks. My name is Nishi Singhal. I'm a program officer with the consortium, and we're really excited to bring you this month's episode. Monthly Monday Primary Care Talks is dedicated to interviewing guest speakers from across Texas, covering a wide range of primary care topics. Each month, we are bringing you informative episodes as your go-to resource of all things primary care. Today, I'm really excited to welcome Elena Marks. Elena Marks is a senior fellow in health policy at the Baker Institute. Today, she'll be talking about the Texas Non-Medical Drivers of Health Consortium. Her work focuses on achieving health equity in the US by reforming the $4.1 trillion health system so that it produces positive health outcomes, not just medical services. This work includes incorporating the delivery of and payment for non-medical interventions into the system when appropriate to improve health outcomes. Elena has been affiliated with the Baker Institute in a variety of capacities since 2010. Previously, she served as a founding president and CEO of the Episcopal Health Foundation, a $1.3 billion nonprofit from 2014 to 2022, and as a director of health and environmental policy for the city of Houston from 2004 to 2009. Earlier in her career, she practiced law and started, built, and sold a successful law-related business. She holds a bachelor's degree from Emory University, a law degree from the University of Texas School of Law, and a master's in public health from the University of Texas School of Public Health. I'm excited for you to meet Elena and learn more about her work. Let's go to the show.
Thank you so much for joining us today. We really appreciate your time. And I'm really excited for me to learn more about you, but also our consortium to learn more about your work. And so I would love to start off with you telling us a little bit more about yourself and then how your work impacts our primary care system in Texas.
Okay, well, thank you so much for inviting me to speak to your constituents. I am a lawyer by training with a master's in public health, and I got into the field really from the policy end because I was very interested in understanding who gets health care, who pays for it, and who decides. And I started really focused on health care access and health insurance, um, and spent a lot of time working really to increase access to primary care. In 2004, when I became the director of health policy for the city of Houston, Houston at that time had one FQHC. And it had a single site and not a lot of patients. And I was part of a group of people that worked really hard to bring up a number of FQHCs. Now I think there are 13 entities with something like 80 sites in Harris County. But at the time, there was almost nothing. And so through my role at the city, I worked with others to help bring up the FQHCs, to make space available for them in city clinics, to help them gain traction in the community, and was really happy that we had a lot of success in building FQHCs and really adding to the primary care capacity for the city of Houston, which has had, always has, at the rate we're going, always will have a very large percentage of uninsured and low income residents. And so it was really important to help them access basic primary and preventive care. And I did that for a number of years. And after a while, I also worked a lot on implementation of the Affordable Care Act. I had finished at the city when the ACA was enacted, and I was over at Rice and at the Baker Institute, which is a policy think tank. And we were really interested in how the ACA was going to roll out in Texas. And again, it was about how do people get access to health care. And it was very exciting work. And we understood the potential of the Affordable Care Act. And we know today the significant number, more than 2 million Texans have marketplace plans, highly subsidized plans for some people, people who might not have had the ability to buy health insurance that was affordable without the ACA. Unfortunately, we do not have the Medicaid expansion, which would have allowed another million Texans to get affordable health insurance, actually free health insurance. But notwithstanding all of that, we've made great strides in increasing access to primary care and to all kinds of health care. But over time, what kept nagging at me was the notion, and coming from a public health background, you'll appreciate this, that most of what drives health outcomes has nothing to do with health care. If you look at all the research that there is, it shows that 80+% of health outcomes have nothing to do with healthcare, primary care or otherwise. And so I got very invested in trying to understand how it is that we have a $4.3 trillion national health budget, and yet our health outcomes on some of the most basic standards are so dismal compared to other developed countries, and began working on the idea that we need to retool where those healthcare dollars are spent. Right now, out of the 4.3 trillion, about a third of that is spent in hospitals in acute care settings. And so much more of it is spent on chronic conditions, some of which are only managed when they're really exacerbated. And so the idea behind the work we did at the Episcopal Health Foundation was, how do we move dollars upstream, whether that means taking it out of a hospital and putting it in an ambulatory setting, whether it means taking it out of specialty care settings and making it available in primary care settings, particularly in community-based settings. And more than that, how do we keep moving those dollars upstream so that they actually help people get access to food and exercise and transportation and housing opportunities, some of the basics that have a greater influence on health outcomes than their access to medical care actually brings them. And so from that, and as I retired from Episcopal Health Foundation, we understood that there was a moment in time when there was a lot of attention on what the state of Texas now calls the non-medical drivers of health. You know, historically, we've all called it social determinants of health, but the state has named non-medical drivers of health, and I'm delighted that they're talking about it. And so happy to use the terminology that suits the state. And as they became more interested, and as we had more incentives and opportunities and increasingly requirements from the federal government for screening and connection to meeting health-related social needs, it seemed like this was a moment in time to bring Texans together who were interested in how we integrate non-medical services into the healthcare delivery system. And the consortium is that product. We are the only space in Texas that is devoted solely to the integration of non-medical services into the healthcare delivery system. We're interested in the practitioners who are doing it at practices, clinics, primary care providers, health systems across the state. We're interested in the researchers who are looking at what works under what circumstances for what populations, with what costs and what benefits. And we're interested in the policymakers and advancing policy that incorporates this work into the healthcare system and that uses healthcare dollars to finance this work, since this will actually improve health outcomes. And so that's the purpose of the consortium, and we've been really pleased that people from across the state have been clamoring for a place that's just talking about this topic, where it's not a session at a conference, it's not an add-on to something else, but where there's a space just dedicated to this work.
I love that. And I actually had the chance to attend your conference, and it was amazing, to see the turnout, to see all the different types of organizations and stakeholders represented. It truly felt like a holistic group of people. And so, do you mind just bridging the connection between non-medical drivers of health and primary care, and really why are non-medical drivers of health relevant to primary care or to our consortium's network? Why is this something that we should pay attention to?
Well, the way that we most understand the need to attend to this actually comes from primary care physicians, from primary care practices. We heard from them over and over that they were frustrated with sending their patients back out into the same environments that made them sick. And they felt like they weren't doing the best job they could do, because they were limited in just doing medical things for people. And when they had patients, whether it's, they don't have a refrigerator and so they can't keep medicines that need to be refrigerated, or they don't have access to a healthy food and so their diabetes is out of control and they're more dependent on medicine than they need to be. And so it's really the primary care workforce that raised the alarm in the healthcare sector that we're not doing what people need. We're not giving people what they need. We are fixing broken people. We are not helping people stay healthy. And it's the primary care provider who has the relationship with the patient and who has the most exposure to the patient. I mean, if you're talking about specialty care or acute care, you're talking about episodic care during a time of need, but it's really the primary care workforce, not just the physicians, but the entire team that interacts with the patients and sees on a day in and day out basis that they have all of these non-medical needs that just aren't being met. And they were really the ones, and some of the very best programs in this space were developed by, for, and through, and delivered by primary care practices.
Yeah, that makes so much sense. And actually, do you mind, in your own words, really defining what high quality primary care means? My assumption is that you are going to, kind of make the connection between the non-medical drivers of health and the primary care delivery system. But how would you define it in your own words?
Uh, I think of primary care as the center, or what ought to be the center of the healthcare system. And instead, we have a hospital centric system. Primary care is something that everybody needs, wants, and deserves. For all of the other kinds of care, not so much, or not all the time. And so I think of primary care um, as the place you go. That's the doctor or the clinic, the practice that knows you the best, that knows everything about you, that frankly has the hardest job, because you walk in with anything in the world going on, medical or not, and you deliver that information to your primary care doctor, who's supposed to figure out what you need in the medical world and what you need in the non-medical world. And it's, to me, the most critical part of the healthcare system, the most underpaid and undervalued, and the part that really is the connection to the non-medical services, because you're the one who is seeing people hopefully in a prevention capacity with regular checkups and screenings. And you're the first line of defense, whether it's I've got COVID, I've got strep throat, um, my arm hurts. And so I guess I think of primary care as the core of the system. I know we don't treat it that way, we don't pay for it that way, but if I were redesigning the healthcare system, primary care would be at the center, and the hospitals and specialties, et cetera, would be spokes off of the hub that is primary care.
Yeah, that's such a great visual. And I'm kind of combining two questions into one, but I would love to hear a challenge that you're currently working on alleviating. And kind of the second part to that, what do you believe your first, step, your first tactical step is in integrating, non-medical drivers of health into the healthcare system? I know, at the December conference, I heard a lot of people talk about the health information exchanges, of course, changing the payment system, a little bit about policy as well. But as we're looking at the challenges, I think there's so many challenges. So I guess, what is one challenge that you're really focusing on through the consortium, but also, what do you feel like, if you had a magic wand, what would that first, change be, to better implement this into our system?
Well, the first change would be payments reform. The limitation, I mean, there's more limitation than just financial on why this work hasn't expanded. Some of it has to do with the medical sector saying that's not my job. That's generally not true of primary care, but you hear a lot of, I was trained to treat and diagnose. Why are you asking me to do something besides that? I think that sentiment is shrinking, particularly in more recently trained physicians who have a more holistic view of what their jobs are. But even if you have the right attitude and you want to do this, if there's no funding for it, you're not going to do it, or you're not going to do as much of it as you could. And so, unless and until we change the payment structures that encourage, maybe require this work to be done, then we're not going to see it. All that being said, um, almost any practice can do this. Now, I'm thinking in terms of group practices. If you're a solo practitioner, the likelihood that you can set up a food pharmacy is not so great. But if you're talking about group practices, and particularly those that are serving underserved communities, whether you're part of an FQHC or other kinds of systems that have primary care community-based practices, you can do this, and you have the data to do this. You know who your patients are. If you're doing any screening, you know what their needs are. Even if you're not screening for social determinants, if you have data that will show you who's hypertensive, who's diabetic, who's got uncontrolled diabetes, you know this because your medical record collects this data. And if you collect this data and you determine that 30% of your patients have uncontrolled diabetes, and then you look at what their socioeconomic status is, which correlates highly with whether or not they're able to access healthy foods, you can build a program around that. And so we're seeing so many practices build food pharmacies and other kinds, or food prescription programs, other kinds of programs that are helping them get their patients access to healthy foods, and measuring the impact to see that they actually have changes in their health status that are clinically measurable based on having healthier food. And so I guess I would say there's some low-hanging fruit, that there are a lot of practices that are that they're willing to do it. They are willing to spend the money to do it, including raising money if they don't have it in their own profit and administrative fees. But they don't always know how. And so one of the things we're really interested in doing in the consortium is matching you up with a similar kind of provider who's already done it. And don't reinvent the wheel. People know how to do this. They can teach it to you. And our experience has been that those providers who are doing this work are really proud of it and are very willing to share their playbooks.
Yeah, thank you. I love that. This has been really great, to get to know you more, and of course your work. And of course, people will have the website to your consortium, as well as your contact information. So, I'm sure there will be lots of questions and lots of sharings that people want to send your way. But we really want to thank you for your time today.
Well, thanks for having me, and we welcome all comers. We are a learning organization, and we look forward to having as many primary care teams participate with us as possible. And we're, helping people lead their colleagues.
Thank you so much. We appreciate
Thank
it.
you.
Thank you for watching today's monthly Monday primary care talks. I know I had a really great time getting to know more about Elena and her amazing work and how it's impacting our primary care system, how it's helping our primary care system. In the email from which you found this recording, you will find a bio so you can learn more about Elena, but also please contact her if you have any questions and just want to learn more about her work. We also have a website link to the consortium that she shared about today. And if you have any feedback for us, we'd love to hear from you. So please simply reply to the email from which you got this episode. If you have guest speakers that you would like us to interview, or if you would like to be interviewed yourself, we would love to hear from you. Thank you so much again, and we'll see you next time.